Good evening, everybody, and welcome to the 9th session of the Kolkata Anesthesia Academy, Apollo Gleneagles Hospitals, and the HCP Education Forum web-based lecture series on anesthesia. It's a pleasure and privilege in having you. What we will do is, before, ask you to put in your questions into the chat box. And at the end of it, we will scan through it, and whatever are the questions, we will take it at the end of both the presentations. And if you don't like the shirt that I'm wearing or the slides that I'm showing, please feel free to comment on that as well. We entertain those kind of comments. We are very, very liberal. All right, so this is about anesthesia in a patient with end-stage renal disease and dialysis. And we know, again, I think this is needless to say, somebody who has end-stage kidney disease, somebody who's on dialysis and undergoing a surgical procedure, the perioperative mortality morbidities are much more if they did not have any ESKD. And one of the classic referred is this 1,157 patients who underwent major surgery like abdominal aortic aneurysm. The perioperative mortality for undergoing open repair was 16%, 10% with an endoscopic repair. And this is much, possibly 4 or 5 times higher than the normal expected morbidity mortality rates are. And why is this so? It is essentially the classic combination of a person with end-stage kidney disease also having coronary artery disease, some kind of an LV dysfunction, the thin balance about perioperative fluid management, electrolyte imbalance in the perioperative period, especially hyperkalemia. We'll spend a lot of time on hyperkalemia. Their association with bleeding diathesis, bleeding complications, the challenge about controlling blood pressure, and both, and they are so labile. So the autonomic things that go wrong with these kind of patients is kind of the reason. They have an innate higher need of vasopressors as well as antihypertensives than the population without ESKD, and they have much likelier to go on a mechanical ventilator in the perioperative period, and their length of stay in the ICU, if they reach the ICU, also in the hospitals, are higher. So what I will take you through, hopefully within the next 45-50 minutes, is define CKD or as well as end-stage renal disease, end-stage kidney disease. We'll spend some time about dialysis and about the types, the concerns, especially the things that are related to anesthesia. Comorbid associations, I'll pick and choose a few, not go through everything. Cardiovascular system is something which bothers us. Coagulopathy bothers us. Anemia bothers us a lot. Diabetes, of course. And then just nuggets about the perioperative management. As usual, we'll start with the poll questions. And Jyoti, Arnav, if you're ready, we can just put in the poll questions, please.
Yes, sir.
So again, like before, if you have been here before, there is this question, and you will have 4 options to those. All you have to do is pick the most appropriate option. And again, it doesn't. It's not an examination. It's just to kind of make you also involved with this. Otherwise, in these days of webinars, it's very difficult because I'm not able to see you. You can't see me. Whatever. So a 55-year-old end-stage kidney disease on twice-a-week hemodialysis is posted for a gallbladder surgery. So what should be the preferred plan? Admit the patient on the morning of surgery, check the potassium. If it is less than 5.5, proceed for surgery. Or admit on the morning of surgery, dialyze without heparin, check the potassium, if it is 5.5, and then proceed for surgery. Or is it admit the day prior to surgery, dialyze, check potassium less than 5.5, proceed for surgery the next day? Or admit the day prior to surgery, dialyze without heparin, check potassium less than 5.5, and proceed for surgery the next day. What I would be looking for, or what is the most appropriate It's not that you cannot do either of them, but what would be, in your opinion, the most appropriate way to get around this scenario? So please put in whether it is 1, 2, 3, or 4, and we'll close the poll in 5, 4, 3, 2, 1, and 0, and go to the next poll. And this is very straightforward. Which of the following is not true for peritoneal dialysis? Peritoneal dialysis cycle should continue as far as possible till the initiation of surgery. The dialysate should be drained prior to surgery. The drainage of the dialysate leads to an hyperglycemic response. And peritoneal dialysis does not need heparin, which is not true. Dialysis should continue as far as possible till the initiation of surgery. Before surgery, the dialysate should be drained. The drainage of the dialysate leads to hyperglycemia. Heparinization is not needed in peritoneal dialysis. I think this is straightforward. 5, 4, 3, 2, 1, and 0. And we'll go to the next poll. Okay, the third poll is a 68-year-old female, end-stage kidney disease on dialysis, BMI is 32, has got reflex esophageal disorder. Her hemoglobin is 11.5, potassium is 5.9, and ECG shows peaked T waves. She's been posted for a laparotomy for intestinal obstruction. Okay, and so obviously this is kind of emergency. You don't have much time. So you need to intubate the trachea. So what will be your preferred neuromuscular blocking agent for intubating the trachea in this lady? BMI 32, gastroesophageal reflux disorder, potassium 5.9, ECG peaked T waves. So your relaxant of choice to intubate the trachea would be suxamethonium, rocuronium, atracurium, or cisatracurium. Again, this is very straightforward. All you have to do is pick up which one do you think is the most preferred neuromuscular blocking agent. Kidney disease, BMI 32, reflux disorder, potassium 5.9, peaked T waves, laparotomy for intestinal obstruction. We'll close the poll in 5, 4, 3, 2, 1, and 0. And go to the next poll question. Okay. A 65-year-old female, end-stage kidney disease on dialysis, needs urgent obstructive hernia surgery. So it's urgent. So you have to kind of get in within the next 6 to 12 hours. On examination, you find that her AV fistula access site is oozing. So she has manifestations of bleeding, and she's end-stage kidney disease, is on dialysis, and needs an urgent surgery. So for the bleeding manifestation, or to control the bleeding, or to take management of bleeding, what would be your preferred approach? Dialyze without heparin, give desmopressin, cryoprecipitate, and platelet, or would it be dialyze, desmopressin, cryoprecipitate, and fresh frozen plasma? Dialyze without heparin, desmopressin, cryoprecipitate, and protamine. Dialyze without heparin, erythropoietin, cryoprecipitate, and platelet. So essentially what we are looking at, this is a patient with end-stage kidney disease needing an urgent surgery, emergency surgery. You find that the AV fistula access site is oozing. So there is a bleeding manifestation somewhere over there. And how would you take care of the bleeding? And you have to go in for the surgery very, very quickly. Heparin, without heparin dialysis, desmopressin CPP platelet, dialyze, desmopressin CPP FFP, dialyze without heparin, desmopressin CPP protamine, dialyze without heparin, erythropoietin CPP plus platelet. So which is the most appropriate response? We'll close the poll in 5, 4, 3, 2, 1, and 0, and go to the last poll question of the evening. Okay. This is again 69-year-old, needs a non-urgent hernia surgery. Okay, it's not an obstructive hernia or a strangulated hernia. She needs a hernia surgery. You find that her hemoglobin is 7.1. On investigation, she is not iron deficiency. She does not have coronary artery disease. So what would you prefer to do in this scenario? Would you admit the patient, transfuse 2 units of PRBC and proceed for surgery? Admit the patient, transfuse 2 units of PRBC, 2 units of FFP, 2 units of platelets, and then proceed for surgery? Or would you hold surgery, administer erythropoiesis stimulating agent? I'm sorry about this spelling of erythropoiesis. We're too much in love with erythropoietin and erythrocytes, and this extra E's appeared over there. We target a hemoglobin of 10 to 11 and then admit for surgery? Or is it hold surgery, administer the ESAs, target hemoglobin greater than 13, and then admit for surgery? So it's essentially about how are you going to manage anemia in a patient with ESKD on dialysis, not iron deficient, no coronary artery disease. Preferred approach, is it just 2 units of PRBC and go ahead and do the surgery, or 2 units of PRBC, 2 units of FFP, 2 units of platelet, proceed for surgery? Or you say no surgery now, administer the ESAs, target the hemoglobin between 10 and 11 and then admit? Or you say no surgery now, give ESAs, target the hemoglobin around greater than 13 and then admit for surgery? So what do you think is the most appropriate response? We'll close the poll in 5, 4, 3, 2, 1, and 0. So thank you for participating. We'll get back to the answers at the very end, and we'll just tell you about, as I said, the first agenda is to kind of, especially since this is a target for the postgraduate students, there will be something which will be a little boring for the practitioners, I think. So CKD, or chronic kidney disease, is a group of disorders which there is an alteration in both the structure of the kidney as well as its function. And it can have various manifestations. The operative word again is that it should be there for more than 3 months. So then is when you called not AKI or acute kidney injury, but a chronic kidney disease. The term the end stage renal disease or kidney disease refers to a chronic kidney failure which then needs dialysis or transplantation. We'll go back to this a little more, and this is just a slide to show the gradual progression. Essentially, if you can screen the risk factor, modify the risk factor, then you possibly can prevent the damage and these complications. And if you can work on it, if you can diagnose early, slow down the progression, you can possibly decrease the decrease in GFR and the attending kidney failure, which has a very bad prognosis. So this is the spectrum of the disease. Just a few things. There's most of these, all these things, these chronic kidney disease, the definitions of end stage renal disease, the definition of when does it become stage 5 or what to do, comes from basically these organizations like the National Kidney Foundation, the Kidney Disease Outcomes Quality Initiative, and the Kidney Disease Improving Global Outcomes. The KDIGO is possibly the most looked at. They came out, their last, I think, thing was in 2009, to the best of my knowledge. The staging is by the disease, and essentially, I think the second part is the category of the glomerular filtration rate, which puts them into what stage they are. And the people have added albuminuria along with it, and that's where you add A1, A2, A3. GFR is the one that all of you would look at, and this is again for postgraduates. Few things. Don't worry if I'm running fast, as you all know by this time, and if you don't know, I'll just say it again, that these slides will be available in its entirety at the eduhcp.forum. So maybe after today is Friday, by Sunday for sure they will be available on the website, so you can go back to them and revisit things if you think you have missed it. So the normal is 125 ml per minute per 1.73 meters square. And when it becomes less than 15, you say it is kidney failure. And we'll just take you through the stages. Above 90 G1, it is normal or high. And it is between 60 to 90 that you say it is mildly decreased. And between 30 to 60, it is mild to moderate to severely decreased. Less than 30 but greater than 15 is severely decreased. And the end stage or kidney failure is when it becomes less than 15. So just to put it into perspective, this is an important slide, especially for the postgraduates, to figure out how do you classify based upon the GFR as to the stage of kidney disease. The other one is the stages of albuminuria, and this is the albumin extraction ratio. And again, this is very theoretical, and this helps in essentially classifying how much it has bearing on anesthetic management. I'm not very sure, but it definitely would have kind of implication on the prognostication. Duration is again that 6 months, as I told you before, to differentiate it from acute kidney injury. And this in one slide will try and tell you what are the structural damages and the functional problems that you have with kidney. I kind of find it easy if I break it down into the anatomical parts, and then it's changes. Is it a glomerular disease? Is it a vascular disease? Is it a tubulointerstitial disease, or is it a cystic disease? And you'll find that what is causing this, like something like a systemic disease like diabetes, autoimmune, or a systemic infection will cause glomerular disease. A vascular component causes renal damage, things like hypertension, ischemia, microangiopathies. And the tubulointerstitials are classic urinary tract infections, stones, drug toxicity can cause. And then the commonest polycystic cystic disease is the polycystic kidney disease. And even in this day and age, the easiest way of diagnosing the type of kidney problem or the pathophysiology is by looking at the urine. And RBC cast, WBC cast, or the fat bodies or the granular cast gives you a clue as to what is the pathophysiological changes that are happening. So that was about definitions. I'll come to the preoperative evaluation. If you look at the preoperative evaluation, a lot of it will be similar. Physical examination, general lab investigations. What is special would be that try and figure out, is the person on dialysis? What kind of dialysis? Hemodialysis or peritoneal dialysis? What was the reason why they initially went into dialysis? Was it electrolyte problem, volume problem, metabolic problem? And along with it, the evaluation will necessarily mean comorbid status. What is the state of anemia, nutrition, but focus on the cardiovascular disease. This is what I would try and do now. Bleeding diathesis and glycemic control. Lab, I think it will be kind of similar. More emphasis on electrolyte values, glucose, blood urea, nitrogen, creatinine, calcium, phosphorus, magnesium, more for a nephrologist, maybe a little less for us. blood count, coagulation profile becomes very, very important, and kind of can guide you as to when you need. Phosphorus, the nephrologists are very, very particular about it, and because the way of managing the dialysis is greatly dictated by that. I am not very sure as to how much of implication it has for us. Do you need to do more above this? I think that it will have to be necessarily individually decided and determined. The one thing that I would possibly stress upon, that especially if they're on dialysis and you have things like digoxin or certain anti-epileptic drugs where there is a narrow therapeutic index, or something like maybe even warfarin, some people would say that it may not be a bad idea to look at drug concentrations at a periodic level, even prior to a particular procedure. This, I think, is unique for this group of patients who come in for a surgery, is the assessment of the axis. Figure out, especially if it is hemodialysis, where is it happening? Does the person have a perm cut into the neck, or does it have something into the subclavian? Does he or she has a fistula? Where is the fistula? Is it in the cephalic area, or is it in the antecubital area? So please figure out whether the fistula looks okay. There is no signs of infection over there. It's not oozing, as I think we saw in one of the poll questions. Mark it out, and because you need to take care of it when the person is anesthetized as well. So coming to dialysis, I think this is something of an approach that I have developed, or rather we have developed in our institution. Is like, first is, why was the dialysis needed? What is the type of dialysis the person is on? Has the dialysis been efficient? What markers am I looking at it? And then I think this part, the last three, becomes very crucial, is the timing of dialysis. If it is an elective surgery, when should ideally the dialysis be done? If it is an emergency surgery, do you still have a time to do the dialysis? Or has the dialysis been done and then subsequently the person needs to be wheeled into the operating room? And there could be things like a medical emergency, like an elevated potassium values, or an elevated or a bleeding diathesis that you think is happening, and dialysis is going to take place or should take place, and the surgery is to happen as well. So these are the issues that we need to actually delve upon before we embark. Why was it needed? As I said, it would be because of these reasons. Volume is possibly the greatest thing, most common indication. Rising urea, rising creatinine, and acid-base disorder and electrolyte values, and acidosis, that renal tubular acidosis, and hyperkalemia could be the main reason. So what was the reason? If you can try and figure out what type of dialysis, it will be either hemodialysis and peritoneal dialysis. And if it is so, how frequently does it happen? Because that you will figure out has to match with the timing of surgery. And peritoneal dialysis, is it a continuous ambulatory one, or is it periodic ones? And again, what are the cycles, and what is the dialysate, and how much? And try and figure out that you have to take care of the dialysate before the person comes into the operating room. Not exactly dialysis. You might have patients on this CRRTs, as you said, the renal replacement. Classically, this is like a filter, not dialysis, and I'm tried and removed it from the purview of this discussion. And it is unlikely, unless the person is in extremis, that a person on CRRT is going to come into the operating room, is likely to stay in the ICU, because the person has been unstable, that is not being dialyzed and is on CRRT. So this is the timing, and this is, I think, very important. It should be either the day or the night before the day of the procedure. So if the surgery is planned at say 8 a.m. in the morning tomorrow, this is the best time possibly for the dialysis to happen. The platelet functions, the metabolic milieu, the fluid status are possibly at its best within that window of, many call the 8 to 24-hour window. So that is possibly the best time when the dialysis should happen before a planned procedure. Peritoneal dialysis generally performed until just prior to the procedure, and the dialysate should be drained prior to the procedure. So this is the two things about peritoneal dialysis, and one important thing about hemodialysis. Efficiency of dialysis, nephrologists look at the target weight, and if they attain the target weight, they say that the guy is doing well. But be careful about, and they only tell you that unless there is a reason why he's losing weight, like maybe it's a malignancy or malnutrition or whatever, we look at it more at the angle from urea, creatinine, and electrolytes, and possibly the pH to look at the efficiency of dialysis. So a person on dialysis, you know the potassium values, and how do you decide that you can proceed or when not to proceed? Unfortunately, no specific guidelines, but I've kind of will give you a rough guide as to what should be done. So to proceed or not to proceed, vis-a-vis hyperkalemia, there are a few things that needs to be taken into account. What is the urgency of surgery? Can the surgery wait for 3 to 4 hours or possibly a little more, or 6 hours? Is there a way that I can fit in a dialysis for a couple of hours at least and then take the person up? Because a couple of hours is enough to correct potassium at least through a dialysis. How much is the likely tissue damage that I am expecting? And therefore, then if I am expecting a huge amount of tissue damage and huge amount of release of potassium, my threshold for accepting a particular potassium value will be lower. What is the anticipated blood loss and fluid shifts? Again, that this is again in consultation with your nephrologist and your surgeon. You decide as to how much that you don't want the person to get negative on the dialysis. And am I expecting an impending acid-base disorder, and then and do I have the time to get this person through dialysis? So these are the factors that should be borne in mind. So to solve the potassium conundrum, we throw another hat in the ring, is the role of the ECG. And we know that the potassium, how it influences the ECG is not by the absolute serum potassium value, but the transcellular potassium gradient. And this hyperkalemia induced depolarization of the resting membrane potential is what leads to inactivation of the sodium channels and therefore a decreased membrane excitability. So whatever ECG changes that you see is because of the transcellular potassium gradient depolarizing the resting membrane potential and inactivating the sodium channels and decreased membrane excitability. The kind of consensus opinions that occur is that it's the transcellular gradient, and it is not the absolute serum potassium values, and there it is essentially because these patients inherently have a higher total body and intracellular potassiums, and therefore unless the serum potassium goes to around 6 or 6.5, that you will not see ECG changes. There are two things that are disturbing in this, is that the ECG changes are not always orderly, that yes, at 7 I see this, at 8 I see this, what is classically taught in textbooks, and you might have no changes but a sudden cardiac arrest with an hyperkalemia also happening reported. So just be careful about this. This is, I think, we'll see in all textbooks. What are the ECG changes? Tall peak T waves when it is between 5.5 and 6.5. Loss of P waves happen around 6.5 to 7.5. Between 7 and 8 is the widening of QRS. And above 8, you get arrhythmias and asystole. And students, if you want to get into this, please come back and look at this at the Edu Forum and figure out what the changes are. So this, I think, is the answer everybody looks for. What is that potassium value at which I say, yes, go ahead for surgery? Or what is that potassium value at which I say, no, surgery cannot be done? I think we come to this. This is that 5.5 milliequivalent per liter. This is the high normal value. For elective surgery, induction with a value less than 5.5 is generally reasonable. What will happen if it is 5.5? Ideally, dialyze the patient. And as I said, unlike a full 4-hour cycle, 2 to 3 hours of an hemodialysis will typically suffice to prepare a patient for surgery. So this is about the ideal potassium value, elective surgery. But if it is not an elective surgery, if it's an emergency surgery and you find that the potassium is 5.5, ECG, there is no change. Again, this is again from the consensus opinion that have been arrived at, that you can proceed with surgery in this scenario with a continuous intraoperative ECG monitoring, and you should have the ability to measure potassium values at very regular intervals, maybe every half hourly. So emergency surgery, you cannot take the person to dialysis. This is what you can do if you see that there is no ECG changes. If you find ECG changes, if feasible, dialyze. Again, for that 1 to 2 hours, which is enough to prepare the patient. What if you cannot dialyze? Then you will have to look at alternative temporizing medical management. So the potassium is above 5.5. You cannot dialyze. It's a life-saving, acute emergency, life-saving surgery, maybe for a hemorrhage, for a bleeding vessel that you need to go in right away. So if you have an ability to do it intraoperatively, a CRRT in that scenario, maybe, but temporizing medical management. And again, I will not spend much time on this. I'll just tell you what the temporizing methodologies are. But if you want to go again, come back and have a look at it at a later time. Medical management, temporary medical management is calcium, insulin, glucose insulin, or bicarbonate. I'll just pause here and say, why did I say temporizing management? It is because this will not remove potassium from the body. The potassium stays within the body. You are trying to send the potassium inside the cell and therefore change the transcellular gradient, or you are taking care of the membrane potential, and that is by an agent like calcium. So you are not sending the potassium out. The potassium is still inside, and this is why with medical management, you will have to keep repeating. Calcium for hypercalcemia is IV calcium, calcium chloride 500 to 1000, and it directly antagonizes the cell membrane actions of hyperkalemia. This is how calcium would work. You can give gluconate or chloride. Chloride contains 3 times the concentration of elemental calcium, but chloride is very, very irritant. It's very unlikely that you can give chloride through a peripheral vein. You have to give it through a central line. So calcium gluconate, therefore, is the more preferred approach. How much you give it is 1000 milligrams. So 10 ml of a 10% solution. If it is calcium gluconate, in chloride, you can start with 5 ml of a 10% solution. Continuous cardiac monitoring is crucial. And if the ECG changes persist, you can repeat this after 5 minutes, and you can keep repeating it. It begins within minutes, but is very short-lived, lasts for 30 to 60 minutes, and therefore, if you are managing with calcium, you'll have to give something else as well, whether it is glucose insulin or bicarbonate or diuretics, or think of other ways. but because this will come back to you. How about insulin glucose? This is, as I told you, drives the extracellular potassium into the cells and therefore is reducing the gradient. If the glucose levels are less than 250, give insulin and glucose. And the usual protocol that most people follow is 10 units of a regular insulin bolus shot, followed by 50 ml of 50% dextrose, essentially 25 grams of glucose. Follow it up by a 10% dextrose of 50 to 75 ml at 50 to 75 ml per hour. You will have to keep monitoring the blood glucose levels. That is absolutely essential. Again, this is an important slide. How do you manage hyperkalemia with the glucose insulin? And I think if you can't remember it, go back and have a look at it. But this is how it works and how much you need to give. And I said this is by enhancing the activity of the sodium-potassium ATPase pump that it drives the potassium inside, especially the skeletal muscles. The effect begins within 10 to 20 minutes. It peaks around 30 to 60 minutes. And that's why repeated monitoring of potassium and glucose is essential. And it lasts a little longer for 4 to 6 hours. The potassium can drop by the regime that I told you, 10 units bolus, 25 grams glucose by around 0.5 to 1.2 milliequivalents per liter. This is an interesting trivia. Patients with renal failure are resistant to the glucose lowering effects of an insulin, whatever it be the reason, where resistance of the receptors, but the hypokalemic effect, they are not resistant because the sodium potassium ATPase activity is still enhanced. If the pH is low, then there is a cause in adding bicarbonate therapy at 1 to 2 milliequivalent per kg. It again drives the extracellular potassium into the cells and reduces the transcellular gradient. That was about temporarizing. How do you remove the potassium? The most efficient way is obviously the kidney itself. If the kidney is not functioning, then obviously it is dialysis. And then the others are diuretics and the cation exchangers. And this, to remember this, diuretics alone in an hyperkalemic emergencies will not be effective. You'll have to add something else with it because the kidney itself is not functioning. The other issue with dialysis is volume overload and fluids, because if there is a fluid overload and there is a pending surgery, if it's overloaded, this is, I think, very intuitive. They can run the risk of going into pulmonary edema, which was also a reason for them to get into dialysis itself. So an optimal volume status is very, very essential prior to surgery. And how do I decide? And this is where it's a multidisciplinary thing. Again, this is where your surgeons and an anesthetist input is extremely crucial to the nephrologist. If there is a huge anticipated fluid loss, they will not make it that negative. So what happens if there is this communication not happening and you do not reach the classic or the ideal volume status after a dialysis prior to surgery, or during surgery, the person receives too much of fluids? Remember that fluid clearance through their inherent kidney is not great at all. So they run the risk of going into an hypervolemic pulmonary edema status, and they then would possibly need an IPPV to just manage the pulmonary edema and an early return to dialysis, which is what is not removable. At the same time, if you remove too much of fluid, they will have hypotension. Anesthesia-induced systemic vasodilatation is the reason. And this is not desirable, especially if they have an arteriovenous access site, because severe dehydration can lead to thrombosis, we know, and these sites can get blocked. So the goal of dialysis is, am I reaching the target weight? additional factors, as we talked about initially: potassium, urea, creatinine, and the pH getting into a normal range. Then comes the issue with heparin and dialysis, and you throw in surgery in between. If you are forced to do dialysis on the day of surgery, ideally it should be an heparin-free dialysis. If heparin has been given, it takes at least typically 4 hours after heparin termination that the coagulation factors start coming back to normal. So if you are pushed into, please do wait for that 4 hours before you get the person in for surgery. And peritoneal dialysis, we talked about this, does not need heparin administration. This is in a scenario, as I said, person has had dialysis, and immediately after dialysis, there is a scenario by which the person needs to be wheeled into the operating room. You cannot wait for 4 hours, 6 hours. The best way of then neutralizing heparin is nothing else other than protamine. So that was about dialysis. I will come to quickly about the comorbid status and how can you optimize. Anemia status. If the hemoglobin is low, they fare poorly. And if the hemoglobin is low, as we'll figure out, you will have to, just like in other patients for chronic anemia, you have an algorithm going and figure out what is the iron status. And if the iron status is low, give them iron. If the iron status becomes normal, give them the erythropoiesis stimulating agent, ipotins, alpha, or whatever. Because, as I said, untreated anemia in a patient with end-stage kidney disease has increasing mortality and disabling symptoms, more if they have to undergo a surgery. So you have to get the hemoglobin levels up. And so the person has a symptomatic relief, as well as very, very important that this mitigates the need of a blood transfusion. PRBC transfusion, as you remember, because always think in mind, these are potential candidates for a renal transplant, and you don't want them to receive a kind of an antigenic insult. So if that is hemoglobin levels are less than 12, evaluate like you would do. Same plethora of studies, find out the iron levels, or is the person losing RBCs. And this, again, very busy slide. This is for postgraduates. Please come back and have a look at it. I won't bother my head to find out what is inside there. So the indications for an erythropoiesis stimulating agent is patient with a hemoglobin of less than 10 and is not iron deficient. Please, the way forward is to give a erythropoiesis stimulating agent. The few places where you cannot give is if you have a potentially curable malignancy or a history of stroke. The adverse effects of ESA is higher in this group. The target level of hemoglobin in a person with ESKD dialysis is between 10 and 11.5. Hemoglobin above 13 has been also found to be of as a bad prognostic marker, especially after a procedure. PRBC transfusion, easy way out. It immediately raises the hemoglobin levels. Why we do not want, as I said, if they're potential candidates for renal transplant, you do not want an immunological sensitization, plus the standard things: overloads, iron overload, fluid overload, transfusion reactions, infection. Few things that we bother about: hypertension. Now, hypertension could have led to this disease, or this disease could have led to hypertension. And the trick about this again needs your consultation with a nephrologist. If you think that this hypertension is due to volume overload, simple dialysis, reducing the volume in the body, can reduce the blood pressure. And if you get the desired target weight and you still find the hypertension, then definitely the need of an antihypertensive therapy is needed. If you need to do it quickly, these are the standard drugs which all of you would know. I think this is again a classic thing as to what blood pressure levels will you accept prior to even an elective surgery. I think this comes from, again, KDIGO, also comes from the ACC/AHA, that you have no business in denying surgery if the diastolic blood pressure is less than 110 millimeter of mercury and the systolic blood pressure is less than 180. If only the diastolic greater than 110 or a systolic greater than 180 would you need to manipulate this, because these patients are used to a higher forward pressure flow for organ functioning, organ perfusion. There is a potential of harm if you suddenly start therapy to suddenly reduce the blood pressure. So please do not do it. Cardiovascular evaluation, it's about coronary disease and the LV dysfunction. 50% of these patients with ESKD and on dialysis will have this. The evaluation is just like what we had discussed during the cardiac evaluation by functional status, ECG, non-invasive testing, and finally, if needed, coronary angiogram, if you think that will change the way we manage. Other disorders are like things like venous thrombosis are more common, peripheral vascular disease is more common, cerebrovascular disease is more common, more likely to have pulmonary hypertension, more association with atrial fibrillation. What bothers us is also heart failure, and the heart failure is mainly could be due to fluid overload, manifests more if there is an attended left ventricular diastolic dysfunction. If there is a systolic dysfunction or a valvular heart disease, they can go into failure quickly. And this, I think, is important, unique to this group of individuals, that if they have an LV dysfunction and you add a fistula, you could commonly see that after a fistula surgery, they suddenly go into failure. And this is the reason, because this hyperdynamic circulation in a patient with LV dysfunction can throw them into heart failure. Signs, symptoms are the same. And unfortunately, one of the markers, like the natriuretic peptides, may not be very kind of informative, because there is a peptide, because it needs to be cleared by the kidney, and in a kidney disease they're not cleared, so they would have an elevated value. So what is the value for kidney disease? I tried to find, I could not. If somebody knows, please put it in the chat box. Bleeding diathesis. Uremic bleeding is a known entity in this group of patients, and you can have the marker could be, as I said, axis site, and that could tell you that they have a bleeding tendency. Why do they bleed? Because of these antiplatelet agents that they might be on because of the coronary disease. Uremia itself causes platelet dysfunction. They could be on anticoagulation because of their AF. Could be due to the residual heparin during dialysis. Anemia releases NO, which is also a platelet function inhibitor. What can you do when you think there is going to be uremic bleeding? Well, easiest is PRBC transfusion, but you're going to hold it. The drug of choice is desmopressin. IV, I don't think you would get it in our scenario. You would get the nasal drops, classically used for reducing in diabetes insipidus, but can be used for uremic bleeding as well. And then is cryoprecipitate. Dialysis helps. Many people would say that people on chronic dialysis, the benefit is lesser. If they have been heparinized, as I think this I've talked about, it takes around 4 hours for the coagulation factors to stabilize. And should we take a patient in for a dialysis immediately after surgery? I think the recommendations are that you do not do it because of this increased bleeding tendency, and you may not be able to figure out where they're bleeding if it's especially a cavity surgery. So try and shift the dialysis after around 48 hours. And if you are forced, then you have to do the heparin-free dialysis. The standard tests of coagulations are done, but what can tell you about the uremic diathesis is possibly tests of platelet function more than anything else. And platelet aggregometry is possibly the best test to look at. Not many institutions will have the ability to do it. Or the point of care tests like TEG and ROTEM can help you to understand what is going wrong and institute therapy that was. Again, for postgraduates, if you want to look at what are the platelet function tests, please come and revisit this particular slide and the next one. It could be a short note. So it's suspected bleeding dialysis, planned elective surgery. What do? I say it is the double D, dialysis and desmopressin, and wait for 24 hours after the dialysis and then go in. The best period, as I said, is that 8 to 24 hours. This is the essential information about desmopressin. The effect begins within 1 hour and lasts for 4 to 8 hours. So you have to give it just prior to the procedure. If suspect excessive bleeding, do not have time for dialysis, then the only thing that you can go towards is desmopressin. And if a dialysis had happened and the person comes in, then the only drug that you can then take recourse to is protamine. Platelets can be given. You need possibly 1 apheresis units or 6 units of platelets. But the problem with the platelets, it will function for a brief period of time, because the circulating platelets will, again, because of the uremic changes, pathophysiology, those transfused platelets will also be subject to the same changes and will get dysfunctional. And this is again important to realize that platelet count therefore may be very high, but they could be still be having a platelet related coagulation dysfunction. Cryoprecipitate has been tried because they can receive this increased amount of factor VIII and the von Willebrand multimeters and increase the fibrinogen levels. So you can give cryoprecipitate. And if you are pushed to giving blood, then the best blood is the leukocyte reduced or the irradiated blood. Diabetes, like hypertension, it could be the cause which cause this end-stage kidney disease. When do you treat hyperglycemia? If it is above 180. And glucose intolerance, as I said, is a feature of uremia. And surgery because of the neuroendocrine stress response, impairment of insulin secretion can lead to an hyperglycemic response. 2 trivial facts, but remember, type 1 diabetes mellitus may be very brittle in a patient with ESKD than those without. A single unit of insulin can make these huge fluctuations, changes between 120. So be careful about the insulin that you're giving. Just the reverse, in type 2, they are more likely to have profound hypoglycemia, especially when they are fasting, because the oral hypoglycemics, remember, are working for a longer period of time. So when they are fasting, it may not be a bad idea that you run a small dextrose infusion into this group of patients. What happens with peritoneal dialysis and the glycemic response? The insulin requirements of peritoneal dialysis may change depending upon on what rate these exchanges are performed. The dialysate has a huge glycemic load. So, and we discussed that it should be continued and it should be drained prior to surgery. So when you are going to drain the surgery, this was the glycemic load. And this, once the drain, when your dialysate is removed, they can possibly go into a hypoglycemic response. So the glucose levels can suddenly fall after the dialysate has been removed for peritoneal dialysis. Other system, pleural effusion, pulmonary edema, gastroparesis has some bearings for us because of the reduced gastric emptying. Again, there could be inflammation of the upper GI tract and could be because of that the bleeding manifestations. Coming to the anesthetic management, premedication is about aspiration, prophylaxis, and anxiolysis. Just, I think, very, very theoretical about this sodium citrate, and because of the phosphate binders, you can have increased absorption maluminium. I think it's very theoretical. I think this is about all medications because of the decreased glomerular function, because of the decreased tubular function, because of the increased volume of distribution, because of the decreased protein binding. Most drugs would have an exaggerated response and have a prolonged response. The same will be with midazolam. Very important is vascular access, especially if they have a fistula in situ where the dialysis is happening and a hemodialysis catheter. So in that arm where there is a fistula, no venipuncture, no vascular access, except in a case of emergency, and you cannot find any other access, is done. Don't try to go and do it. Please call the technician in the dialysis ward. He or she will be much more efficient, and he or she will not spoil that access, which you and I can. During the surgery, take care of it so that there is no inadvertent puncture or there is damage to that access at any point of time. Should I use a hemodialysis catheter for drug administration? The recommendations, I would say no. But again, if you are forced, you do not have any access, then you can take recourse to this. The general considerations, I talked about this, is same. It's about this, the drugs not getting excreted, drugs getting prolonged in the body. Is regional anesthesia useful in patients with ESKD? It can be, because it can reduce the potentially hazardous general anesthetics. The avoidance to administer multiple IV anesthetics are reduced, and it obviously produces superior analgesia, requires less of systemic analgesics, especially NSAIDs, which you are not able to give, so you give definitely superior quality of pain relief. The catch to this is, remember, they can have bleeding diathesis. Please do check the coagulations before you give anything. Residual anticoagulation after heparin administration will be there at least for 4 hours. And so if you're putting in an epidural, removing an epidural, the timing becomes very, very important. The other two things about local anesthetic is more theoretical. Induction agents, the preferred induction agent is propofol. The pharmacokinetic and pharmacodynamic response are not markedly altered. But if there is elderly, like a patient with failure, you will have to obviously decrease the dose. It's the same. Few words about muscle relaxants. Suxamethonium remains the drug of choice for rapid sequence induction intubation. Remember, the risk of aspiration is higher. It is safe as long as the potassium is less than 5.5 and there are no ECG changes. The increase, like in a healthy individual, is around 0.5 to 1. And because of the decreased plasma cholinesterase, the duration of action of SCH will be higher. So now you have a potassium which is more than 5.5, but the person does not need a rapid sequence induction intubation. What will be your muscle relaxant of choice? You will obviously avoid scoline or suxamethonium. In this scenario, the muscle relaxation of choice will be obviously one of either atracurium or cisatracurium, because they are organ independent elimination, but they're slow in onset, so not a candidate for rapid sequence induction intubation. You have a scenario, again, potassium is high, but this person needs, like one of our poll question, needs rapid sequence induction intubation, then what muscle relaxant will you go for? The answer would be rocuronium. 1 milligram per kg. Rocuronium, though, has liver metabolism, but some of it is excreted renally, so the duration of action of rocuronium will get increased. Reversal with rocuronium nowadays, not for us, but in the West, is with sugammadex. Sugammadex is typically avoided, but if you have given sugammadex, then it might have to, because it's such a huge molecule, you have to dialyze and remove it. Which is better for maintenance? Is it intravenous or is it inhalation? I think it's very intuitive, because inhalation is eliminated through expiration. Inhalation agents possibly are the more suitable ones for maintenance. People have talked about the renal toxicity of sevoflurane, and I think this examiners love to kind of grill students on this. I don't know why, but about this formation of compound A, only seen in rats with low fresh gas flow, high temperatures, not demonstrated in clinical practice in humans. About opioids, short-acting opioids are the ones to go out and avoid the long-acting opioids. Reversal neostigmine remains just like what it was even without end-stage renal disease. About sugammadex, we talked about it. Fluids, I think this is something which is very confusing. Do you use crystalloid? Do you use the potassium-based crystalloid? Should we use only normal saline? What about dextrose? How much to give? I think it has to be very, very individualized. You cannot have a blanket answer to this. Hyperkalemia, when they are NPO, the go-to fluid should be glucose. Avoided obviously in hyperglycemia, or if there is hypokalemia, the glucose fluids. And typically, like if they're coming in for a procedure, you are going to check for potassium values, check for glucose values. If they're in intensive care, they would check for potassium values, and whether you're going to give a crystalloid with potassium or not will be dictated by that. Post-operatively, it will also depend upon the attended, what has been the type of surgery, what is the associated comorbid conditions, whether they go to an high dependency or an intensive care. When is the dialysis going to happen? Again, preferably after 48 hours. All these decisions, again, has to be a collected decision. If they become something that the pH is going down, potassium is rising, and you have to go in for a dialysis, if you have and they're hemodynamically unstable, then the go-to would be continuous renal replacement therapy. That is, I think, a complete different area of interest altogether. Post-operative pain management, multimodal, but avoid NSAIDs, avoid long-acting. Paracetamol can be given. Regional techniques preferred until and unless there is no coagulopathy. And short-acting IV PCA fentanyl can be very, very useful in this group of patient population. So I will finish with the answers to the poll questions. So end-stage kidney disease, twice a week hemodialysis, and needs to come in for a gallbladder surgery. What should be the timing of surgery? I think we discussed this. Ideally, the day before or the night before. So admit the day prior to surgery. Dialyze. You don't, because you're going to wait for more than 4 hours. Dialyze with heparin. That's a more efficient way of doing it. Try and check. Do a potassium after the dialysis. Should be less than 5.5. Proceed for surgery the next day is possibly the most preferred approach. I think most of you got it similar to what I thought. Not true for peritoneal dialysis. It does not lead to hyperglycemia. It leads to hypoglycemia. The rest of it is true. I think this, everybody got it nearly. So you need to have rapid sequence induction intubation. Potassium is high. ECG shows peak T waves. The go-to muscle relaxant will be rocuronium. Cisatracurium, atracurium, you will not be able to do a rapid sequence within 60 to 90 seconds. Now, this is about bleeding diathesis correction, the preferred approach. This is urgent obstructive hernia. You don't have much time. The best would be dialyze without heparin, wait for that 4 hours. You don't have to wait for the 4 hours because you need to go in possibly early. And then the go-to drugs would be desmompressin, cryoprecipitate, and maybe platelets. And non-urgent hernia surgery, you want to build up the hemoglobin in a person who is not iron deficient. The go-to approach would be the erythropoiesis stimulating agent. Target the hemoglobin between 10 to 11 or 11.5, and then admit for surgery and do this planned surgery. Thank you very much.
Thank you very much. And first of all, my sincere thanks to SCP Forum and Saikat for sharing the dais with you. and my talk will be on the anesthesia management for renal transplant. I do not have any conflict of interest, and this talk is based on mostly on the evidence and experience based. So, why I am speaking on this topic? Number one, because the renal transplant surgery has become a very common, and most of the corporate hospitals are doing. Any hospital which have the nephrology, ICU backup, license for the transplant, they can take it up. We started the transplant in 2005. Saikat myself is well equally like for my as if both of us are equally involved in the transplant program in Apollo Hospital. And then we formulate the team of the nephrology, the surgeon, and the anesthesia department. And till now, I think since inception, we have done around 1,500 good outcome transplant in our institute. So, I mean, why then we take the patient for transplant? So, there is a good clear-cut evidence that all the patients who are end-stage renal disease, that means the GFR is now less than 15% and they cannot have any excretory function, they are all potential for the transplant candidates. And despite that there is a alternative of dialysis, still the transplant is considered because it is, it changed the quality of the life and the survival benefit is higher than the dialysis. The patients who are remain on dialysis, the mortality is 70% almost, and that is due to the specifically due to the cardiovascular events. So it has got a tremendous advantage over dialysis, including cost and the quality of life and the repeated hospitalization. So the transplant is always considered in most of the patients, and those criteria has been extended on the recipient also. So there are few contraindications, which is actually nephrology's domain, like active cancer, metastatic cancers, infections, and the comorbidities which our expectant life expectancy is less than the benefit of the transplant. Those candidates, we do not take it for them. The graft survival is very good, like 1 year's graft survival is 98% and 5-year survival is 83%. So there is a good reason that every patient, end-stage renal disease patient, should get a chance for the transplant. This slide just to show you, on the left hand side, this is the reducing GFR from stage 1 to stage 5, and on this side there is albuminuria. So both of these are the indications, and the grading of the end stage renal disease is done by this. And you see, as this the GFR goes down and the proteinuria increases, the green zone becoming this yellow, and within the stage 3 it becomes orange, and the red, that means the chance of death is very, very high. Now coming to the systematic effects of the end-stage renal disease, and you can see this slide that you take any organ and the effect of the renal dysfunction will affect that system and the organ, because the pathophysiology of the disease is as such that it affects everything. It affects the microvasculature, it has the role in inflammation, it has the excretion difficulties and the toxin accumulation. So right from the skin to the toe, that is what we say. And I remember one of the statement of Dr. Mani, who is the renowned nephrologist of India. I had opportunity once to hear him, and he said, if he's a Padma Bhushan, by the way, he said that if you find a patient with a vague symptom and vague complaints, and you can't think anything of else, just do a urea creatinine. So it is like that. So any system, you take any system and you will have the disease, right from anemia to the cardiovascular, respiratory, neurological, GI, everything, liver. So coming to the pathophysiology at the end stage renal disease, I'm talking. So what causes the symptoms basically? So we know the kidney has basically 3 modalities of the function. One is excretory, metabolic, and endocrine. So contrary to the belief that accumulation of urea and creatine actually does not cause any symptom, but it is the metabolic products of the fat, protein, and the carbohydrate. They are the water soluble and water insoluble products. They basically causes the toxemia. There are some acids and some metabolic products, and when that excretory system and metabolic function comes almost to the halt, we call it uremic syndrome. So all these three dysfunctions will come together, and patients will have the signs and symptom of all these dysfunction like volume overload and hormonal disbalance, and the most importantly I want to take your attention here about the systemic inflammation, which is not mentioned in most of the textbooks, is that the renal dysfunction and end-stage renal dysfunction and the dialysis that induce the systemic inflammation in the general system, and that is the one of the perhaps the most important cause of accelerated atherosclerosis, and that is the reason we find most of the times increase C-reactive protein, whether it is the marker of inflammation, and the decrease anti-inflammatory markers like fetuin. So how they present when we see them at the time of transplant? So it depends on what stage you are seeing the patient. If we are seeing them, say, absolutely in early stage when the nephrologist refer in the outpatient basis in pre-anesthesia clinics, we might see patient with all the symptoms. Patient may be severely anemic, patient can have cardiomyopathy, they may be volume overload, they might have edema. You take any symptom and they might have. If you see the patient just before the transplant, they might be completely optimized and completely asymptomatic, or they might have a very vague symptom. So it depends on the stage of the renal failure when you are seeing. If they are with the volume expansion, then you will obviously see the hypertension, edema, and dyspnea. And there you might have to see the patient after the dialysis with hypovolemia and hypotension. That is not a very uncommon thing. So if the patient is having hypotension, that means too much ultrafiltration has been done, and that may need to correct before the transplant. Potassium is usually taken care by dialysis, and if we must, and normally in end-stage renal disease, the potassium sometime, especially in diabetic nephropathy, because you know the main pathology of the end-stage renal disease, almost 50 to 60% patients have diabetic nephropathy. So they affect the distal tubules and aldosterone metabolism, and then the hyperkalemia is more evident in those type of patient, and some patient may be acidotic also. So what are the preoperative concerns? Number one, when you work as a transplant anesthesia, then you have to think of not only the only recipient, but what their outcomes will be, and what are the other factors other than the clinical management. That what type of donor it is. It may be live donor or deceased donor. Why it is important? Because the live donor, you get the enough time to prepare the recipient, and if it is related, then the outcomes are much better because their cross match are usually they match. And versus deceased donor, where you do not get adequate time for the recipient preparation. Within few hours, you might maximum you might have get the dialysis of 2 to 3 hours, and you have to go in. So in deceased donor recipients, you will have the whatever the comorbidities unoptimized, you will have to take it on. The dialysis itself, the patients who are on dialysis, they have the duration of the dialysis has the direct correlation with the patient's post-operative outcomes. The lesser the dialysis duration gives the better outcome, and that is where the role of preemptive transplant. That means the patient who are having end-stage renal disease, but they are not requiring transplant. If we transplant them before they go on dialysis, the chances of survival are very high. But the difficulty is preemptive transplant means they have never dialyzed, and the nephrologist might refer him to directly to take the patient for transplant. But it is very essential to evaluate them as any other patient about their anemia, about their cardiac status, about their acidosis, about their potassium, everything. And if needed, we usually dialyze them a day before. Cardiovascular is one of the very important preoperative concern, because as the previous speaker has very extensively elaborated about the cardiovascular risk, is perhaps the most important concern for us during the surgery, because that is the adverse cardiovascular events are extremely common, almost in 48% patient to 50% patient. They are common. In fact, even the post-transplant duration their cardiac risk is still remains, and there most of the time the post-transplant mortality or morbidity is directly associated with the cardiovascular component. Equally important is the nutritional condition because their outcomes are depend on the albumin level, their muscle mass, and the respiratory. Coming to the cardiovascular system now, ischemic you have already heard it, but I'll just put some additional point that ischemic heart disease is the major concern in the end stage renal disease, because there are traditional risk factors are already there, like hypertension, uncontrolled hypertension, and diabetes, maybe history of smoking, maybe family history of coronary artery disease, they are already there. On top of that, there will be additional risk factor related to the uh, chronic kidney disease like hypervolemia, hyperphosphatemia, that is the direct correlation with the ischemic heart disease. Then there is a increase in cardiac load, workload. That means the very high systemic vascular resistance, high load of catecholamines. These are the additional homocystinuria. So the homocysteine anemia, sorry. So they all put this additional risk in regards to the ischemic heart disease. Additionally, they have anemia, they have phosphate accumulation, they have parathyroid hormone dysfunction, and dialysis if you find the patient before the transplant whose blood pressure is on the lower side, that is not a good sign. That means they might do worse than the hypertensive patient. Chronic heart failure is very common, and the inflammatory state, which I already mentioned. The inflammatory state gives the atherosclerotic plaques, and that is the hidden or silent coronary artery stenosis or ischemic heart disease is very common. And the high troponin level is also seen on the repeated values without ischemia, and the traditional treatment may not benefit in CKD because their pathophysiology totally go out of proportion, and despite they are on beta blockers or statins or any therapy, the progression may not be halted as in general population. So their scoring is always on a high risk side. So any patient who come for cardiac transplant, renal transplant, as the cardiac risk score is always high, because they are usually they are elderly, they are diabetic, they are insulin dependent diabetic maybe, and high creatinine. That itself put their cardiac risk score in higher than the normal. Heart failure is because of the volume overload and hypertension. The diastolic failures are the worse than the systolic failures, because and they do not behave well. Like systolic failure, the treatment is they respond to treatment better, but in diastolic failure, their outcome is not very good. So you have to be careful in fluid management in the diastolic failure. And additionally, they may have the endothelial damage in the pulmonary circulation, and that can lead to the low pressure pulmonary edema, what is called the bat wing sign. Anemia and sleep apnea can additionally put the risk in as a reason for the heart failure. Now coming to the hypertension, it is the double-edged sword, already mentioned by the previous speaker, that they aggravate each other. And hypertension, especially in elderly patients, severe hypertension is a poor prognostic sign, because what is happening is that hypertension induced comorbidities like cardiac and neurological, they keep on progressing, and because of the better medical facilities, their life expectancy is going up, but at the same time their renal dysfunction is progressing. So the smallest reduction in GFR can induce renal failure risk also very high, and the cardiac risk is also very high. So they will have the more vascular disease, I mean atherosclerotic disease, than the younger population. So old age population, that is why their post-operative long-term mortality is higher than the young patient. The reasons for the hypertension are very well known: renovascular, sodium retention, volume overload, and the renin-angiotensin system overactivity. Left ventricle hypertrophy along with the cardiomyopathy, usually they have dilated cardiomyopathy, is the strongest risk factor for the cardiac risk. And treatment is targeted to actually prevent the extrarenal complication like any other general population, like cardiac risk or the neurological risk. But the BP target is not, although guidelines say that 130/80 or 140/80, but they are not applicable because usually they go beyond the autoregulation level. Hematology is already discussed. Their anemia and anemia induced their symptoms are very they precipitate LVF or they precipitate angina. So nowadays most of the patients are on erythropoietin and their target hemoglobin is at least about 10. Um, and the hemostasis is, they usually have the bleeding risk, but at the same time for the unknown reason they have hypercoagulation state also, so they will have the risk of thrombosis. But when you give any anticoagulant therapy or heparin therapy, we need to be very cautious for the risk of bleeding. The risk of bleeding is always more than the risk of thrombosis. Neuromuscular, all the components affect equally. Cognitive dysfunction, peripheral neuropathy for us, autonomic neuropathy is very important because their blood pressure fluctuates very fast. And depression, they might be on the antidepressants medications. Now, what workup we need is an optimization. One is nephrology side, they have their battery of tests like cross match and consents and administrative sanctions. What we need is all the blood tests for all the routine functions like complete blood count, coagulation, liver function tests, ECG, X-ray, and echocardiography for all the patients. Although if you see the guideline, they might say healthy patient, just ECG and X-ray is enough. But from our own personal experience, all the patients should have a baseline echocardiography because surprisingly you find the very active patients with a very young age, you find ejection fraction of 35-40% with dilated cardiomyopathy. So it took almost 3 months for our nephrologist to convince that why every patient needs echocardiogram. And depend on the each systemic abnormality, then you can escalate the investigation and optimization like any other general population. It is very difficult to diagnose occult cardiac disease because of very confusing symptoms and very similar symptoms. Like patient have a complaint, they will complain of chest pain. It can be just pericardial pain, and patient who have dyspnea, whether it is because of the failure or volume overload or real failure. So it is very important to go through the then optimize. Usually respiratory system, it is not that badly affected. Usually the only thing they have is most of them are prone for tuberculosis. So chest X-ray is mandatory, and if they are having pre-existing COPD, then you can go for the further tests. Now this is of the one from the chart from the they recommend that very healthy patients and less than 50 age, you just need a asymptomatic patient, just ECG and chest X-ray. Asymptomatic low risk renal transplant patient. Now asymptomatic low risk is very few, so most of them fall in the high risk category. So anybody who has high risk, that means established CKD with old age diabetes and history of cardiovascular disease, they should undergo the stress exercise tolerance test. And if that is positive or that is inconclusive, then you go for the dobutamine stress echo or then thallium scan, and depend on that you can go for the further for the angiography. Among all the screening tests, the dobutamine stress echo is the most specific because it has a very high negative predictive value. Now coming to the intraoperative issues, few I have highlighted and few I have put it in the fade lines because anesthetic agent and the regional anesthesia is already covered with the previous talk. So the intraoperative major issue with the transplant, because that puts a lot of the pressure on anesthetists, and that there is a lot of conflicts of this issue with the nephrology, the surgeon, and the anesthetist. It is better to discuss with your team beforehand what will be your monitoring strategy, what will be the fluid strategy, what the vasopressors and inotropes are chose. About anesthetic agents, it's already mentioned that most of the agents they go through the liver metabolism, and their metabolites are not what we use medication, like they do not alter through the renal dysfunction. But few you have to keep in mind that medicines like morphine, where the metabolite is 30 to 40% active, and that go to the renal excretion. So those things, or vecuronium for that matter, because 30% again the active metabolite goes to the renal metabolism. Those you need to be cautious. Similarly, meperidine. The standard propofol, fentanyl, atraquinone, cisatraquinone, they will have the only effect of the volume distribution or protein binding. About the regional anesthesia in transplant, that is out of fashion right now, because that puts a lot of complexity in managing the blood pressure and fluid, post-operative mobilization. So because it is a low incision, abdominal incision, so epidural analgesia is mostly it is out of. When we started, we used to give epidural, but now we are doing almost minimum invasive anesthesia for the transplant patients. But the blood pressure monitoring, IV fluid, and the vasopressors are the very, very important. Now, blood pressure, coming to the all the three stages, like preoperative, intraoperative, and the postoperative, blood pressure managements and the targets are very, very difficult to manage, and they're equally important. So preoperative target BP, most of the patients is not achieved. We see the patient with maybe 150, 160, or sometimes 190 systolic pressure because of the various reasons, despite they are on the maximum antihypertensive medication. They will see the patients on alpha, beta, combined alpha, beta, and AC inhibitor, AC blockers, diuretics, and whatnot. All the and despite that, their blood pressure remains high because of the high catecholamine or high renin levels. Hypervolemia is always issue, and high catecholamine is also seen. Now, intraoperatively, that is, I think, perhaps the most important concern for the anesthetist is hypotension, because hypotension is considered. I mean, blood pressure during the surgery is very crucial for to maintain, because the graft dysfunction is directly correlated with the blood pressure and the volume. Whatever reason, if there fall in blood pressure, and if the graft is not function, then that can be a big issue with the perioperative outcomes. So anesthesia induced hypertension can be because of the multiple things. Patient is dialyzed or they are hypovolemic. They are more sensitive to anesthetic agents. There is synergism between medication, blood pressure medication, and anesthesia agents. There is autonomic neuropathy is there, and there is impaired compensatory mechanism. All these things can make them very, very sensitive to anesthetic induction agents, and one should be very, very careful. The post-operative, that is the mostly nephrology concern, but usually post-operative also their blood pressure modification needs, because that's a new kidney to the in the recipient, and that behaves differently than the native kidneys. So important. Then how do we manage this blood pressure issue? So preoperatively, they should be maximum optimized. Like, we should see that how much their blood pressure optimization is essential. As previously it is mentioned that you can accept 180 as long as diastolic, but importantly, diastolic blood pressure also needs to be seen, especially in elderly patients where the calcification, the vascular disease is more concerned than their vessels are stiff, there is severe atherosclerosis. So what you will see is the very high systolic blood pressure and low diastolic pressure. Now, if you want to control systolic blood pressure, the diastolic blood pressure will also come down, and that is why in most of the hypotension definition, only systolic blood pressure or mean arterial pressure is given. But the importance should be given to the diastolic blood pressure also, because that is already we are talking about the cardiac complications or cardiac adverse events. So maintaining the diastolic blood pressure is extremely important. Hypertension definitely carries the more risk than hypertension. So at induction, you choose there is no single formula for any induction, but you can choose the multiple drug induction. Use the small doses of multiple drugs to avoid the toxic effect of any single drug. And you must know that the higher the blood pressure you see preoperatively, they are more prone for the intraoperative hypertension, because that blood pressure is actually maintained on the high sympathetic tone, and you give any anesthetic agent and there is vasoplasia and there is a significant fall, up to 50-60% fall, it can go down if you give liberal doses. Like textbooks teaching you that propofol you need to give 2 to 2.5 milligram, because the volume of distribution is high, but most of the patients hardly require 1 milligram per kg. So intraoperative at the induction, just the depth of anesthesia, IV fluid, and the vasopressor is the choice of treatment like any other case. So the blood pressure, again, what are the events that causes the maximum fluctuation of blood pressure is at induction and when they release the clamp. These are the two area where anesthetist has to be absolutely cautious. So if you prevent it, it's better, because it's very difficult to treat. So induction I have already mentioned. During the unclamping, you need to load the patient with the fluids, and the vasopressors should be ready, because that multiple factors affect the blood pressure response during the unclamping. While the laryngoscopy and extubation, there can be surge in blood pressure. So especially during extubation, one needs to be careful, because if the blood pressure rises too high, then there can be anastomotic leak, and that can be catastrophic. Similarly, during the vascular anastomosis, blood pressure has to be kept significantly within the normal range. Now, monitoring. What should be the monitoring in the? Apart from standard monitoring, we are talking about whether the invasive or non-invasive. Now, there is no clear-cut consensus or guidelines about this thing. You can go by individual basis, but usually, like I prefer invasive blood pressure monitoring. For the several reasons, because it is the vascular major surgery, and as we have already discussed, there is a good chance of blood pressure fluctuation very significantly, and the blood pressure is one of the things seen as from anesthesia management, the most important thing by the surgeons or everyone is how the blood pressure was maintained during the surgery. And post-operatively, it can be whether if there was acute tubular necrosis because of what reason, but the blood pressure can be one of the factors can be discussed. So invasive is it gives the real-time measurements, bit to bit, and we can you can maintain the induction. During induction, you can see how trend, what dose the blood pressure is coming down to, where to stop with induction agents, or when you are treating the hypertension, also you can target corrections accurately. Along with that, we need ABG sampling to see the potassium level and pH level before extubation or in between. And in case there is a major blood loss, then the vasopressor therapy can be well guided by the invasive blood pressure. But having said that, a healthy recipient who has no cardiac issues and so you can go for non-invasive blood pressure monitoring also. So that has to be discussed among the team and decide according to your local policy. So one of the reason why people do not, especially surgeons do not want to use the arterial line is future arterial AV fistula. Suppose that suppose artery gets thrombosed or occlude, then that is a waste of the site for them. About CVP. Now, all the guidelines and textbooks say that CVP monitoring is essential during the renal transplant for the fluid management guidance and inotrope or vasopressors. Now, this is again the very, very old concept of CVP, whether it should be monitored or not. I'll come to that. But when we started like epidurals, we used to do epidural artery line central venous pressure for all the cases. But now we have stopped putting central venous line for most of the cases, unless there is a significant cardiac element where the patient can require prolonged vasopressors, or it is a redo transplant, or it is a complex surgery. Advantage is, yes, you can still use the CVP for the fluid management and the vasopressors, but disadvantage is it is definitely more invasive. There is a good chance of rate of complication, like suppose arterial punctures and hematoma. Obviously, with the ultrasound guidance, now it is much more safer. Reliability is the question, and it is definitely infection source compared to the arterial line. Now, second major issue is the IV fluid, which is I must address this issue because there is always conflict. This is, I think, since inception of the fluid, this conflict is going on, and I don't know how many years it will go on. But what I heard in most of the critical care CMEs and lectures is that the fluid should be treated like a medicine. Like we should must know what fluid you are going to use, how much, and what is the target. Now, most of the textbook, like our standard textbook and the guidelines, tells that sodium chloride is the choice of fluid and guided by the CVP guidance. And um, although it is a low quality of evidence, but they uh, recommend sodium chloride as a choice of fluid. Now there is a reason for this thing because of the different practice in the continents. American prefer the normal saline. Physician definitely prefer more normal saline, and the guidelines and the textbooks are mostly Americans. So contrary to the what we have seen the previous talk about the CKD patient, for the non-renal transplant, we go in the conservative fluid therapy. Here exactly it is opposite. So the transplant patient need the very aggressive and the liberal fluid therapy. Why? Because the graft survival is depend on the volume status. Anything which causes hypovolemia like hypotension, the chances of graft failure is very high uh, within the next 7 days. So the if we want, the whole purpose of this exercise is to know the that graft survival. So the all the measures should be taken very cautiously by every member of the team to maintain the graft survival. And one of the very essential thing is the fluid. So adequate fluid. As soon as they release the clamp, the kidney should fill within the second. It should be pink, it should be tight, and if it is a soft kidney, then it is the classical sign of hypovolemia. If it is a tremendous hypotension, then it's a classical sign of hypovolemia. And if that graft doesn't function, the directly blame goes to the low fluid therapy. So it is better to go for liberal fluid therapy because there is a good reasons, because patients are hypovolemic, they are post dialyzed, and in these patients, if they are hypovolemic and even the blood, they maintain the good blood pressure for whatever reason, if the volume goes, even there is a mild hypovolemia, the reflection of blood pressure is very significant. So both way it will affect the graft function. So acute tubular necrosis, one of the reason is hypovolemia, and one must, and they also get the diuretic therapy like mannitol or furosemide. So all the reasons are there to give the liberal fluid therapy so that they will have good diuresis. Now one might say that, okay, why no restrictive, or why we should if there is more fluid there will be edema or pulmonary edema. But we have to remember that patient is already anesthetized, they are on positive pressure ventilation, and even if there is no exact measure to measure whether patient what level you should stop fluid therapy, but it is better to go on a positive side little bit than on negative side, because you can manage the positive side, but managing negative side is very difficult, because if at all patient is on positive side, you might have to ventilate for a few hours, or you might have to go dialysis cycle, which is very rare for the mild fluid overload. But if it is a negative fluid load, then it can create a graft dysfunction. Coming to the what type of fluid you should use, I have put the 4 choices, but 2 choices I already put in the fade line because they are out of practice. You have crystalloid, colloid, albumin, and blood products. Now, colloid is already all controversies have been established. So we do not use the colloid in renal dysfunction, established renal failure case where there will be one functional kidney. Albumin, some surgeon, it's a surgical practice, because if some surgeon wants to use, they might use, but I mean, the evidence doesn't support albumin infusion because it's a expensive colloid. The half-life is short, and in this patient there is a capillary dysfunction, as we have already seen with the inflammation. So if there is capillary dysfunction in the lungs, it can cause pulmonary edema. Blood products are reserved for the specific purpose, so they are not for the purpose of volume loading. Now coming to the whether the normal saline, or sorry, or balanced solution. Now, normal saline is invented almost, I think, 1890. Since then, it is the most common used fluid in ICU and critical care. And the later the balanced solution came because we came to know that that is normal saline have some hazardous effect. Now, coming to the renal transplant, what the fluid should use? Uh, Still, there is a controversy. Still, there is a debate, and still there is a confusion. But if we see what is normal saline, so it is why they use normal saline. Basically, first question, it is the fear of hyperkalemia, because nobody wants, despite the patient is dialyzed, still there is a fear of hyperkalemia is there. And it is normal saline is not a balanced solution because it contains 10% more sodium than the plasma and 150% more than chloride than the normal plasma. So, and neither it is physiological solution. So the pH is 5.4, and you know the acid base is depend on the this anion gap, and if there are too much chloride is you pushed into the circulation, then this anion gap is narrowed, and this goes to the the equation goes to the acidosis side. Plus, the hyperkalemia now is directly related to acidosis. So, any acidosis, hyperchloremic acidosis, will shift the potassium out of cell into the extracellular space. And you know the potassium inside the cell is too large. I mean, 140 milliocumoles per liter compared to 3.5 to 5.5 extracellular. So, slightest shift from the intracellular to extracellular can cause the huge hyperkalemic effect, and that has been shown in multiple studies. That normal saline infusion reduces the renal blood flow, it increases the renal ischemia, and acidosis in turn affect the cardiac output and ventricular function, and even the catecholamine effect on the coagulation. So, normal saline is actually not the fluid of choice. Um, this is the from the Nephrology Society of Spain, that choice of fluid. So there is a huge literature here in this review article that how the normal saline, I mean balanced salts are better than normal saline. And this is the Anesthesia, one of the review article, but this is Australian study published in BJ. So this is the randomized control trial between the saline versus plasma light, and they have shown that the plasma light has a better profile, although the survival benefits are equal. And this is from the American Journal of Nephrology. They have criticized the two trials which say that one trial was between normal saline versus ringer lactate, the other trial was between the normal saline versus plasma light. So in the conclusion, he is asking that, should we broadly abandon the use of isotonic saline, such as recommended by these studies? And the answer is no. But what he is saying that in the majority of the patients who have normal kidney function, are not hyperchloremic, do not have sepsis, and require only modest volume of the intravenous fluid, use of isotonic saline remains the reasonable. But the question is why you should use it, because in kidney function neither patient is normal acid base balance, and they require huge amount of fluid, so that perhaps this conclusion also rules out the use of normal saline in transplants. Now, how much fluid should be given? This statement is from the standard textbook, that adequate intravascular volume expansion with crystalloid or colloid increase the renal blood flow, which improves the immediate graft function. Now, it doesn't tell how much fluid should be used or what fluid should be used. How we need to manage is we have to put some endpoints and monitoring, like medicine. I already said that fluid should be used as a medicine. So the best surrogate markers of the organ function is urine output, mental status, capillary refill, heart rate, and blood pressure. And intraoperatively, none of these are useful. So what is left for us is the heart rate, blood pressure, swings in arterial or pulse oximeter waveform, and the CVP. Now, we have heard for so many years that static measurements are not good and the dynamic measure should be done. Static measure doesn't give any information about the preload. Having said that, if we see the fluid response to the fluid in dynamically, maybe it is heart rate or blood pressure, it gives the good reasonable information about the fluid status of the patient. Say there was a heart rate of 90, you give the 300 ml bolus of whatever crystalloid, and the heart rate comes down by 10%, that is a positive response. Or blood pressure goes up, that is also positive response. I'll come to the CVP, but the PAP is, pulmonary artery pressure is very complex and not used nowadays. And these dynamic monitors are, they are the very special monitors, expensive, and you need an interpreter. So ultimately, it comes to our clinical experience, and you can also use the CVP. Now, CVP has been criticized long, very heavily recently, that we should not use CVP. So this is one of the very good article, and this is written by professors Louis Vasa and Daniel Debaker, both of the great authors and speakers. I have heard them several times. Both are from the Brussels. So what they wrote about it, that although we criticize, but it is most frequently used modality. I mean, in ICU or in theater, we talk about dynamic monitoring, but how much, unless it is only useful in cardiac anesthesia but the most of the time post-operatively, ultimately we come to the CVP monitoring. Variability, we criticize with CVP, but the other measures are also depend on the variables like blood pressure and heart rate. And we know that if the fluid response is poor, we will not administer the fluid. But what is important is that all the trials have been shown that 8 to 12 CVP gives the better fluid response. That means the CVP is less than 8, you can give the fluid. More than 12, you can stop giving fluid. More than that, change in the mean arterial pressure without increasing in the CVP is the positive response of the fluid. So CVP still we can use. I mean, trend, if you use, there was 4 CVP and now it has become 8, that is a positive response. So it is still, you can use the CVP as the fluid guide. Now, how much fluid? That is also, there is no single formula. Somewhere between 30 to 50, and some literature has said that up to 80 ml of fluid per kg, I mean total fluid you can give in the recipient, depend on their post dialysis status and their response and the blood loss. You can give continue, you can give bolus, and you have to keep the patient's status on Starling curve, whether they are in the responsive state or unresponsive state, which is difficult, and which is each patient will be on the difficult level. But aggressive fluid definitely you need during induction, at the clamping and declamping. You have to also remember, when they clamp the iliac vein, the CVP goes down because of the decrease in preload. Now, hypotension definition and treatment. So when there is hypertension, you have only 3 choices: either volume or depth of anesthesia and vasopressor or inotropes. So what choices we have here is either you have mephenteramine, you have phenylephrine, or norepinephrine. And what is the target of blood pressure? As I already said, as much as close to the preoperative value or within 20% of the preoperative value with euvolemia. You cannot give vasopressor with hypovolemia. Now, this is the one study, interesting paper, incidence of intraoperative hypertension as a so this paper has said that he found 140 definition of hypertension in 130 different literature, and so the incidence become from 5% to 90%. So at induction, how we prevent the hypertension is, prevention is always better than treatment. Induction of dialysis patient is always comparable like patient in shock despite the normal hemodynamics. They are dry patients, so you have to be very careful. So titrated dose along with the fluid is sufficient, or small dose of alpha, beta, or mixed adrenergic are helpful. If there is a persistent hypotension, what are the choices? You can give the phenylephrine or norepinephrine. Dopamine is again the question of debate, but what we found is the continuous phenylephrine is only alpha blocker, and pure alpha blocker, it might affect the cardiac output in adversely, and in critical care trial it has been found that it might be detrimental because it reduces the venous it increases the venous resistance, so it does not help in increasing the cardiac output. So this is one. So should norepinephrine rather than phenylephrine be considered as the primary vasopressin anesthesia practice? So what he said that is mostly ICU friendly, because preparation is difficult and titration is difficult. Epinephrine is easy. Advantage is it's alpha, beta 1 and beta 2 receptor agonist. So it does not increase the venous resistance, and it promotes the preload movement. It increases the preload, and that is why it helps in increasing the cardiac output. Also, it has got the beta 1 positive inotropic effect. It is more potent, 20 times potent, and it has been found helpful than norepinephrine in majority of the critical cases. This is also one paper from this Belomo. This gentleman has worked almost 25-30 years on norepinephrine, and in animal studies, he has shown that the norepinephrine in modest doses, it improves the renal circulation by improving the overall perfusion of the systemic perfusion, and in small doses, it actually decreases the renal resistance and increases the renal perfusion. So in summary, this I would say that preoperative evaluation, the plan, the knowledge of pathophysiology, the hemodynamic interpretation, and the fluid and vasopressors are the key factors in anesthesia management of renal transplant recipients. Evidence along with the experience-based practice is the key in managing any patient. So thank you very much.
I think we'll just go through the questions. Ravi, there is a question from Dr. Shankho Dash, and he's asking, recent literature favor normal saline over balanced crystalloids in renal transplantation.
Yeah, the literature will be on the both side. Nothing is mentioning, because most of the guidelines still are saying that you can use normal saline. Now the pro normal saline, the literature is they say that because of it is potassium non potassium containing solution, and what they found is that the delayed graft dysfunction or graft survival or patient survival is not altered by whether you use normal saline or the balanced solution. But I do not understand that if we have evidence of having the potassium, like we have our own trial, very well, we have done 150 cases trial in our own institute, and we found that the ringer lactate patients, they do better in acidosis or in potassium level intraoperatively. So, but the guidelines and textbooks, as I said before, the American guidelines, they always prefer the normal saline. Like in ICU practice, we might use balanced solution in operation theater, but once patient goes to the nephrology department, they continue with the normal saline. But strictly speaking, scientific basis, if we see the fluid, details and analyze the fluid balance, the balanced salt solution favors, they are more favorable.
Absolutely. I couldn't agree more. I think about something that our findings itself. I think I'll just go back to a few questions that came up. I think this is from Dr. Swam Sahu, and he's asking whether salbutamol can be used. Salbutamol nebulization can be used to reduce potassium. Yes, it is. It is an accepted therapy. Not very efficient, but if it will be after maybe glucose, insulin, and bicarbonate and calcium, that you think of giving a salbutamol nebulization. So not a very efficient therapy, but yes, it can be done. Dr. Alok Bhattacharya, a good friend of mine, he's asked whether other than propofol, can we use etomidate? Yes, etomidate can be used. Again, the issue with etomidate is that adrenal suppression even with a single dose. So if you are not absolutely forced to because of the cardiovascular situation, avoid etomidate, because propofol, if you titrate the dose, there should not be an issue. All over the world, I think propofol has been extensively used. This is from Professor Jayanto Bhattacharya. Jayanto, thank you for being there and being such huge support. His question is, why does the insulin requirement reduce after a diabetes-induced chronic renal failure goes into hemodialysis? I think the answer to this is that a nephrologist will answer this possibly better than I do. There is always this insulin resistance, and this is whether it is due to metabolic factor or due to the inflammatory factors, that there is an insulin resistance, and it has been observed that this insulin resistance dramatically decrease after a dialysis. Why it does, I don't know. I think you will have to ask your friend Arubda for that. So, but it is because the insulin resistance decreases with the dialysis. Dr. Reshmi is asked whether Ravi, do you have any comments on this other than what?
Insulin, yes, there is a one somewhere I read that in end stage renal disease patient, especially on dialysis, there is more insulin secretion compared to non-dialysis patients, and perhaps that consumed they become the more better, or they can go on hypoglycemia side
Correct. Yeah.
after it. So there is secretion increases marginally compared to non-dialysis patients.
Okay. I think it's essentially the same thing.
Yeah.
There is end-stage renal disease. There is a resistance to insulin. So the resistance is because of the metabolites and
Correct.
the inflammatory
Absolutely.
factors. Plus, there is this issue with also the insulin metabolism that is happening, and there are some people say that the clearance is reduced, so which can offset it. But resistance definitely goes down after a dialysis, and as Dr. Ravi was saying about the secretions part of it as well. About use of fresh frozen plasma instead of fluids in major surgery. First and foremost, Dr. Reshmi, I would say that fresh frozen plasma is not a fluid as such. As for it should not be used as fluid therapy. First and foremost, so fresh frozen plasma should be used where it is actually mandated, like in whether it is when you're managing coagulopathy, which also nowadays many people are moving away from it, and if you especially have access to cryos, because it's a more efficient way of doing. Two issues with end-stage kidney disease would be, one is the potassium. Fresh frozen plasma is a rich potassium-containing fluid, and the other thing is again volume overload. So to correct a given amount of factor 8 or von Willebrand factor that you want to give, a cryo is a much better option. So if your blood bank has able to produce cryos, I think it's a more efficient way. So, and for a fluid therapy, FFP, no. Amna madam, thank you for being there, one of our staunch supporters, and it's such nice. She's made a comment that she has had the opportunity of anesthesia, of providing anesthesia to umpteen subdural hematoma surgeries in a patient with end-stage renal disease, and they strangely behave well. Well done, Amna madam. It is all because of they have been blessed to have an anesthetist like you at the head end, and your blessings more than anything else possibly counts in that. And lovely, and such pearls of wisdom that we get from senior people like you is what inspires us to stay here. And like that acromegaly thing that you told us a few days back, I will remember it for my life. Dr. Abhijit Kormukar, CKD patient coming in for a total knee replacement, what is the anesthetic choice, GA versus regional anesthesia? If there is no, to me, if there is no coagulopathy, it will be a regional. So now, to me, the best option would be a subarachnoid block, and maybe for postoperative analgesia, whether you give a femoral or a adductor canal, that would be my option to go ahead, as long as I know that there is no coagulopathy. Ravi, would you like to chip into this?
Yeah, I mean, what you said, I will completely agree. Just you have to take precaution about you will maintain the renal perfusion, whatever is remaining. So taking care of blood pressure, the fluid management, the temperature is all important issues should be kept in mind, whatever choice you give.
Absolutely. This is from one of our students, Dr. Sengupta Shamra. She is now, this is something that I should get rid of. She's a consultant in her own right at the Institute of Neurosciences, but does neuroanesthesia. The role of mannitol and other diuretics in neurosurgical patients with a background of CKD. There is, I think, if you look at diuretics, loop diuretics, furosemide can be used in a patient with CKD. Now, the mannitol bit, the controversy bit is about in a patient who has established renal dysfunction. The problem with mannitol is the clearance, because it will be excreted through the kidney, and so it's a huge molecule. And if there is renal, there is tubular damage or there is tubular dysfunction, it will not go out. So the residence time of mannitol will be much higher than normal, because otherwise it doesn't take wait for it to get metabolized. It's just excreted through the kidney. So your residence time will be high. So, and depending upon how much of mannitol you have given, the mannitol will keep circulating in the system, and the osmotic effect of mannitol will keep happening. And there are instances where people have been forced to dialyze people to remove just the mannitol as well. So just be careful about mannitol in a patient whose GFR is very, very low, because the mannitol that you give stays in the system till it takes this huge time to go out. I think that is about it, unless there has been any questions after that. So thank you, everybody. It's been a pleasure to be with you all, and thank you, Dr. Ravi. Ravi, thank you very much.
Thanks, Saikat.
And so this for our effort from Kolkata Anesthesia Academy, Apollo Gleneagles Hospitals, and the HCP Edu Forum. And I would ask finally Jayati to give the final word of thanks.
Thank you, sir. I would like to thank Dr. Ravi. I would like to thank Dr. Saikat. And I would also like to thank all the participants who have been joining with us regularly in this forum. So, just to inform you that once this session is over, you will be receiving a link in your registered email IDs to share your feedback with us. Once you share your feedback, which will help us to serve you better, you will receive an e-certificate signed by our faculty. And within 24 hours, you will receive a link to revisit this lecture in edu.hcpforum.com. And not only these lecture, all other lectures which has been conducted in HCP Forum platform. You can visit all those lectures over there. Please take a note of it, edu.hcpforum.com. You need to register here with your registered email ID and put a password, and then you can have access to all the lectures which has been conducted under HCP Forum. So thank you, everyone. Thank you, faculty. We sign off for today. See you soon.
Thank you.
Love
Thank you.
Thanks, Saikat.
Bye.
Bye. Stay safe.